funny. Good morning, everyone. In the interest of trying to stick to the schedule, I think we'll just get started. My name is Dr. Shabina Welji, and this is...
I'm Jennifer Brown, a registered dietitian at the Ottawa Hospital.
And it is our pleasure to be able to chair today's mini review, Government Frameworks for Obesity Prevention and Management. Just so you know what the format of the session is, we have three delightful speakers today who will be sharing their knowledge with us. Each will be giving a 20-minute talk, including questions and answers after each talk. I think we can probably just jump right into it. Our first speaker is Ms. Jimena Ramos-Salas, who will be giving a talk on developments in European nutrition, physical activity, and obesity policies. Jimena is a PhD candidate at the University of Alberta's School of Public Health and the Managing Director of the Canadian Obesity Network. So everybody, please join me in welcoming Ms. Ramos-Salas.
I'm kind of short. There we go. So I can see the TV. That's good. So thank you, everybody, for coming here today. So today I'm wearing my third hat, which is I am a technical consultant for the WHO European Office, where I provide consulting services for the team that's working on obesity prevention and management. And you know my other hat, I work for CON as well. And my third hat is that I'm a PhD candidate with Dr. Kim Rain at the University of Alberta. So as a disclosure, I just wanted to say that I do receive consulting fees from WHO. And the purpose of this talk is basically my direct report at WHO, Joao, called me and said, I can't come. And so he asked me to give his presentation, and so that's why I'm doing it. But what we wanted to do is kind of showcase, and I want to position what we do in Canada and how it fits with the WHO global agenda for prevention of chronic disease and for the management of chronic diseases at the global level. And so my objective today is to just review some of the nutrition, physical activity, and obesity development and implementation strategies in the WHO European member states, and then position them within the umbrella of the WHO Global Action Plan for Prevention and Control of Chronic Diseases. So as we all know very well, obesity is a chronic disease, and hence it falls within the WHO Global Strategy for Prevention and Management of Chronic Diseases. However, as we all fully know, and we heard yesterday, obesity is not really treated as a chronic disease in Canada. So what's the difference in other countries in Europe, for example? We know here from this slide that obesity has been considered and described as a chronic disease by WHO since 1948. And many US and European organizations and Canadian organizations, including the Canadian Obesity Network, have acknowledged that obesity is a chronic disease. The WHO statement about obesity as a chronic disease states that obesity is a chronic disease that requires long-term strategies for the effective prevention and management. However, they clarify that obesity can be defined simply as a disease in which excess body fat has accumulated to such an extent that health may be adversely affected. So again, they have a clause specifically in this report that was written in the year 2000 that BMI is not a good measure of health at the individual level, that is good for surveillance studies and population level studies. However, there's individual variability in BMI, so there's distinct clauses about this in this WHO report, which was written in the year 2000. Here we are, 17 years later, we're still using BMI at the individual level, even though WHO described clearly that it's not a good measure of health at the individual level. But if you position WHO's targets for the prevention and management of chronic diseases, obesity is one of those targets. So WHO talks about obesity as a chronic disease, and they have included it as a global target for preventing further increases in obesity at the global level. In the global non-communicable disease targets, there's 3 things that are specifically related to obesity. And that is decreasing physical inactivity and decreasing salt consumption and basically halting the progression of obesity at the global level. So those are the 3 targets that are specific. So by 2025, the objective is to achieve these goals. So do you ever wonder how we're doing in terms of achieving those targets? Here we go. This is the latest data we have from the WHO European member states. We're not doing so well. Adult obesity, almost zero, none, no progress whatsoever towards those targets. And childhood obesity, a little bit on track, but really we have very poor surveillance on childhood obesity in Europe, so it's difficult to really assess. But the bottom line is, after 17 years, when WHO wrote that paper, that position paper that obesity should be prevented and managed as a chronic disease, we have not made much progress, which aligns with the message that Dr. Sharma was describing yesterday about how in Canada, we haven't made progress in terms of increasing obesity treatment and access to obesity management in Canada either. So childhood obesity, we know in European countries, one of the factors that we're looking at specifically is that it affects children disproportionately who live in lower socioeconomic groups. And so we decided in Europe that we were going to develop a surveillance system. So now, all European member states contribute data on childhood obesity to the study that we call the COS study, which is the Childhood Obesity Surveillance Initiative. And we're now trying to get that data. What is the current state in childhood obesity? Are these, when we say that we are on track a little bit about childhood obesity, what does that really mean? Are we actually describing it properly? Because we don't have very good data. What we know is, unlike what most people believe, the Southern European states have more obesity currently than other European states. And the growth and the rates of increase of obesity in Europe are increasing at a very, very fast and alarming rate in Eastern European countries. And for WHO right now, Russia is a key priority country because the rates are increasing faster than they did in non-Eastern European countries. So we talk about physical activity being one cause of obesity, but when you look at this data here, it basically shows you that children with or without obesity are inactive. So it's very interesting to really critically consider this. When we say that obesity is caused by inactivity, is it really true? At the population level, children are not exercising and are not physically active, sufficiently physically active. It's not just children with obesity. It's all children are inactive. And so if we think that obesity is going to be prevented by increasing physical activity, that's not really the right target that we want to assess. What we want to do is promote physical activity at the entire population in order to prevent chronic diseases, right? The objective is not just to prevent weight gain and obesity. The objective is to prevent chronic diseases. So the priority policy options for WHO are the following. And this is how WHO member states are planning to prevent and manage obesity. These are the top policy issues. Those include reducing exposure to food marketing to children, taxing junk foods, increasing and changing the front of packaging labeling, and reformulating foods so that they are healthier. Reducing calories, reducing salt, reducing sugar, all of that. And changing the food environment so that healthier foods are easier to access. So all of those policies are framed under chronic disease prevention. But because obesity is one of those chronic diseases, we tend to talk about these policy options as obesity prevention tools. And my job at WHO for the last 8 months has been It's okay that these are policy options and these are important priorities, but we cannot solely frame these policies as obesity prevention priorities, right? These are chronic disease priorities, policies for chronic disease prevention, and we need to keep talking about that and change our language and be more inclusive of all chronic diseases, not just singling out these policies for obesity. And when we talk about, we're trying to measure how these policies are being implemented in Europe, implementation is staggered, very low implementation. So that's another objective of WHO is how do we increase the implementation of these policies? So we have great data that, increasing, changing the way that we advertise to children, all of that can help improve the dietary habits of children, et cetera, and that can prevent chronic diseases. But we see from WHO European countries that implementation of those policies is uneven. The progress is uneven, and it's very actually rare that these policies actually get implemented. So there's policies, but implementation is lacking. Same thing with physical activity policies. A little bit better, but still lacking. The implementation of physical activity policies is lacking in Europe overall. So the next steps for WHO is to try to work with member states to try to implement these policies as chronic disease measures, prevention measures, and to scale up some of these interventions that we've planned and monitor and surveillance. So there's a few opportunities within WHO that I wanted to take an opportunity when I went there to work as a consultant. So we know that WHO has a priority to improve nutrition, to increase physical activity, and reduce obesity. And there's several policy frameworks under which WHO is doing this work. The most important one right now in Europe is the Commission on Ending Childhood Obesity. And there's several recommendations here about how we're going to end childhood obesity in Europe. And as you can see, most of them are about changing the food environment, increasing physical activity, but there is one on management. And the key thing that we want to do at WHO is that we want to integrate prevention strategies from policy to also primary care. So there is a role for primary care to do chronic disease prevention, and that is our key message moving forward, is that we cannot just have all these policies at the policy level. We also need to engage primary care in helping us implement those policies because they do have a role. And the Food and Nutrition Action Plan for 2015 and 2020, the Physical Activity Strategy for 2016 and 25 highlight important considerations for primary care. First, primary care is underutilized for preventing and managing obesity and promoting healthy diets and exercise. Treating the consequences is readily accepted. We treat diabetes, we treat, hypertension, which are consequences of obesity, but we don't actually talk about obesity in primary care. We don't actually do very much about obesity at the European level in primary care. And health professionals, just like in Canada, do feel that they lack that training to do that in an evidence-based way. We also know that primary care is a good setting for having those teachable moments with parents and children about exercise and healthy habits. And we can do early interventions. So when we heard Marty's story yesterday about how when he was 13 and his weight was going up, nobody did anything. Nobody helped him. Why? And so in Europe, it is the same situation. Children with obesity are not getting any treatments at all. So one of the things that we're trying to focus in WHO is that we need to make prevention people-centered. So it's not about having this generic policy strategies and then putting everybody in one box. It's about working with patients and people on the ground and figuring out what it is that they need to improve their health and prevent chronic diseases. So putting people at the center is under the WHO strategy for ending childhood obesity. But how we implement that remains to be seen. But really, truly, what the mandate of the WHO childhood obesity strategy is that we need to integrate health promotion, and disease management in primary care in order to prevent and address the social, psychological, physical, and all the other aspects that cause obesity and chronic diseases. So when we see strategies like this to prevent childhood obesity, when we shame and blame, when we use fear tactics to say obesity is bad for you, it causes other chronic diseases, children's life will be shorter because of their weight, because of their obesity, it has consequences. And again, my second job at WHO was to make sure that whatever we do in Europe to change childhood obesity, that we don't create unintended harm for children, that we support them where they're at, but we don't shame and blame. And so the key frameworks under which I convinced WHO that weight bias and stigma is relevant is that the WHO Commission on Ending Childhood Obesity actually acknowledged and recognized that obesity is associated with stigmatization and it affects children's health. The WHO Global Plan for Action on Social Determinants of Health talks about addressing weight bias and obesity stigma and giving people a voice, people with obesity a voice in public health. We're very bad about doing that in public health. We need to give people a voice, and that will help reduce inequalities as well. The Global Action Plan for Prevention of Control of Chronic Diseases talks about, we need to address the underlying social determinants of obesity. Again, this is what Marty was talking about yesterday, right? So, and the last framework under which obesity, weight bias, and stigma fits is the Health 21 European framework for health equity, where weight bias and stigma could be seen as a fundamental issue, a social justice issue. And as we know, weight bias and obesity stigma causes psychological harm to individuals living with obesity, and we need to acknowledge that. So my recommendations for WHO over the last 6 months is to recognize weight bias and obesity stigma as a public health and social justice issue, to monitor and address weight-based bullying among children and youth, to create policies to prevent and eliminate obesity stigma, to assess the unintended consequences of chronic disease prevention activities on the lives and experiences of children and youth who live with obesity, and to consider the unintended consequences. Think about, what does this obesity narrative do? When we frame obesity as solely caused by inactivity and consumption of unhealthy diets, what are the consequences for the narrative of obesity and for the lives of people living with obesity? And address the factors, the true factors that drive obesity, not just physical activity and diet. And to empower individuals with obesity to participate in chronic disease prevention and management health policies. And finally, my last slide is to really treat obesity as a chronic disease. Not just talk about it and put it in all our policy documents, but actually do something about obesity as a chronic disease. Because right now, none of the WHO European member states have true chronic disease strategies for addressing obesity. Adopt people-first language in the health system and in public health strategies and policies. Change the narrative of obesity as a lifestyle choice and the portrayal of individuals with obesity throughout their images. And address weight bias in primary healthcare services and develop healthcare models that support the needs of people with obesity. Create supportive environments to prevent chronic diseases, while also promoting mental health, resilience, and body positivity amongst children, youth, and adults. And that's it. So that was my work at WHO, and I'm glad that you heard it. So if you have any questions, let me know. Any questions?
Yes, we have a few minutes for questions. Yeah, and I actually do have a question. Your last slide actually summarized most of the question I had, but I felt, you had a great point around that we need to change the language, instead of focusing on, the children and adults that have obesity, but focusing on prevention for everybody. Your last slide gave some good points, what we can do, but as practitioners and providers and anybody living with obesity, what are some take-home messages that we can bring home from today that you feel that we could use individually to influence change?
I think the biggest issue that we discussed in my research is that we're not just talking about weight as a behavior, and we're talking about people living with a disease, a chronic disease, and to acknowledge in primary care and in policies that this is a disease that affects people. It's not just about numbers, it's about improving the health and well-being of individuals, and not just focusing on measuring the reduction of BMI in the individual. Yes, we can use BMI at the population level to do surveillance studies, which is important to measure the impact and effectiveness of our strategies. But even if we're not reducing weight, are we actually improving the health of individuals? That should be really the goal, even in public health. So when we talk about obesity prevention, we're really talking about prevention of a chronic disease, and that means improving the health and well-being of people and individuals living with that chronic disease. So weight is something that it's part of it because we're using it to do surveillance studies, but it's really not the right outcome measure for our public health strategies, right? The right public health outcome measures should be more focused on weight and health and well-being of individuals. And so that's why I think at WHO we had the discussion about how, we all need a number. We need something to measure the effectiveness of our policies. We need something that says that what we're doing is working. But right now, when you look at it, we haven't been able to really change obesity prevention. We haven't reduced levels. We haven't really done very much in terms of effectiveness. So are we really shooting ourselves in the foot? Because we may be changing other things. We are doing reformulation of foods, and things are changing, and people are eating healthier, but we're not measuring those things because we're solely measuring BMI as an outcome for public health strategies. So I think that was a discussion about how do we, as a community, develop better outcome measures for our public health efforts. They should not be just focused on BMI. That's it.
Were there any questions from the audience? I think there's somebody here.
1 minute. I can shout. I have 1 minute.
1 minute?
Yeah.
So, what about the debate that is around the notion of calling obesity a chronic disease
Mm-hmm.
when there are many healthy people who are obese?
Mm-hmm.
How do we not get mired in a debate that will just create confusion for the public?
Yeah, so we had that discussion with the team in Europe as well about, we don't want to label people with a disease. In Canada, that would be 6 million people that would be labeled as disease, like having an illness. But that is based on the assumption that we use BMI to diagnose people with obesity. And the WHO definition of obesity clearly states that BMI is not a good way to diagnose obesity. And so we had to go back to those documents from the year 2000 to look at it. WHO never said that BMI is a good way to diagnose obesity. They never said that, and it was clearly described in their documents. It's just that we just kind of got derailed in that number, and everybody focused on that number, and now we're like, okay, let's take a step back and think about that original definition. And the definition says that obesity is a disease when it affects your health. And if it doesn't affect your health, you just live in a larger body. You're just a bigger person. It doesn't mean that you're sick. And so when we train primary care professionals right now in Russia, it's all about getting them to understand that you need to assess the person's health and then determine if that person needs weight management. You cannot assume that that person needs weight management based on just looking at that size.
Excellent. Thank you. Everybody join me in thanking Jimena for her presentation. Thank you. Okay, next I'd like to introduce Dr. Hutchinson. He's the Director General of the Office of Nutrition Policy and Promotion within the Health Products and Food Branch of Health Canada. So please join me in welcoming Dr. Hutchinson.
Thought I'd left left stuff behind from last time I was in. Okay, wonderful to be back. Are there some new people in here that weren't here this morning when I talked? Okay. So for the rest, I'll be repeating a little bit of some stuff here as well. This morning I talked about the food guide, and there's some information that sort of flows through here. What I'm going to be talking about, of course, is our health eating strategy. I mean, this is a session that's supposed to be about government frameworks and stuff, so I'll be concentrating on that. Nothing to declare. So I will give a bit of an overview on the minister's mandate commitments and how we would morph that into a healthy eating strategy. An overview on some of the healthy eating strategy initiatives. I'm going to focus on the food labels, restricting marketing to kids, a little bit again about Canada's food guide, and a campaign that we're putting together right now that has to do with sugar-sweetened beverages. And then allude in one slide or two to the recommendations that came out of the Senate Obesity Report last year as well. I did want to point out that my examples will be a little bit around sugar, given we heard a lot about that this morning as well, so I'll follow through on that. But of course, we're not focused just on sugar. We're not a single nutrient approach, but we only have 20 minutes, so there we go. I think this is pretty obvious for all of you, is that for health eating, there are lots of challenges in Canada. We know that people are not following really a health eating pattern all that well, and that it's a risk factor for obesity and other sorts of chronic diseases, and sort of engenders all sorts of costs as well for our healthcare system. And that the real problem with most of this is not just what the individual is having choice and control over. It's that the overarching food environment is really problematic, and it really almost becomes outside of the control of the person. So even though some of the initiatives I might be talking about come down to making it easier for people to select, I don't want you to think that I think it's all about personal choice. It's all about really creating the right type of food environment so that those choices just become easy to do as well. I'll just move on because we don't have an awful lot of time. One thing with this new government, well, not new government anymore, we're a year and a half in there, that they made a number of commitments public. You know, the Prime Minister sent the letters to all the different ministers about what he expected them to do over the mandate. So the mandate, the 4-year mandate that this government has in office. And for us in health, there were a number here that were talked about making changes with respect to the food labels, new regulations to improve the food supply, specifically with respect to trans fats and sodium, introducing restrictions on the marketing of foods to kids. So those are the sort of things. So, you know, one could have taken the approach that, okay, there are basically 3 files, and we'll just think of them separately and sort of go off on our merry way and respond to the mandate commitments. But we thought of this as a real opportunity to do things differently in Canada with respect to healthy eating, and to a certain extent different compared to most countries around the world as well. And we thought, so how do we actually bring all of this together and use it as an impetus to take a more concerted, coordinated approach to how we change those food environments? So now it's all about a whole whack of different sorts of approaches, initiatives that we're doing that we try and work all together on. Whether, you know, I'm responsible for some of them. The food directorate in Health Canada is responsible for some. First Nations and Inuit Health are responsible for some other ones. And so how do we work together to use all the different levers that we have at our disposal, whether they're legislation, whether they're regulation, whether there's awareness and education campaigns, whether it's dietary guidance or whatever, or research, you know, working with our friends at CIHR to make sure that the right type of research is being done to sort of support all of this. So it's taking that comprehensive approach and really putting a lot of effort into networking back and forth. I mean, the folks across all of these different files meet 3 times a week to make sure that we are on track with each other as well. You know, so it's quite a different way of working on here. So the strategy itself sort of runs through these different sorts of pillars, and, you know, sort of health eating information, protecting vulnerable populations, and that's where we've got the marketing of kids in there, the labeling and claims, nutrition quality standards, that, you know, reducing sodium and the trans fats fall into there, access and availability of nutritious foods, and that's really what the changes to Nutrition North program sort of fit into there. So those are the sort of sets of things where we really want to work differently. We want to reinforce each other. We want to make it easier for Canadians to understand the basic messages and really get to creating a Canada where making that healthier choice is a much easier choice. So just as well, of course, this is all about healthy eating, but at this type of a meeting, of course, physical activity comes into consideration as too. So the minister also has this other vision for a healthy Canada, where healthy eating is just sort of one component of that. We've got what she calls a healthy living component. In there, you will find the physical activity, concussions, the tobacco, the vaping sort of stuff that's there. And then you've got the mental health side as well here, a healthy mind. So as well as trying to work in a very coordinated way with respect to health eating and nutrition, we're also trying to look at where there are possibilities for joint action across these actually different domains as well. And some of these are off in the public health agencies, some are in other branches of Health Canada in terms of responsibility as well. So again, it's that really forcing us now to work more closely together so we're actually being more efficient and more effective. So I will run through then just quickly a number of the different initiatives, just so you get a flavor sort of how we're approaching this. And so improving food labels, I mean, there are a number of different initiatives that we've already done some work on and other ones that we're starting on. The changes to the nutrition facts table, this is one that we had actually been, and this is food director, not my responsibility. I have to give credit to another part of Health Canada for doing this. The changes to nutrition facts table. Now, this was actually finalized in regulations just in December. And with respect to sugars, and I'm just going to point out a few little things where there have been changes. So first of all, on the right-hand side, so the nutrition facts table itself, you'll see that what we have done is to introduce a line about, we had total sugars before, but we've introduced a daily value, and then you have a percentage of a daily value. So you'll have an idea of how many total sugars are in there. And at the bottom of that nutrition facts table, we've actually put in some guidance so that you can actually interpret what that means. So we've got, if it's 15% or more, that means there's a lot of that particular nutrient, and if there's 5% or less, that means there's a little. I mean, this is something that we introduced in a number of years ago in our nutrition facts education campaign that we've ran for about a 5-year time period there, and it seemed to really help consumers to understand how to interpret it. But now what we've done is we've actually, through regulation, put that particular interpretation message right on the nutrition facts table, so it's on every packaged food that you have there. It should make it easy. You don't have to remember how many milligrams, how many grams of this you want or not. Basically, if there's, all you have to remember is, you don't even have to remember it 5 or 15, because now it's on the pack. So if it's more than 15, it's a lot. If it's less than 5, it's a little type of thing. So that sort of makes it easier using that particular tool, the nutrition facts table, to understand where there's a little or a lot, and in this particular case of sugar is what we're sort of pointing out. But that applies across the board. On the other thing that's on this slide has to do with the ingredient list. And the way it is out there right now, and I mean these regulations just came into place, so there's a time period that industry can accommodate and change the labels. You could have sugar sort of distributed among the ingredient list in 5, 6, 7 different places. And of course, you're in the ingredient list based on the weight of the contribution to the thing. So what we actually have in regulation is that we force in the ingredient list that you package all of those sugars together so that there is, in this example, it has sugars down as the first ingredient, and then in brackets, all the different types of sugars that are in there. So they all come together. You still know what different types of sugars are in there, but the total amount of the sugar then pops up to the total representation of sugar. So you have much more information, again, of the total amount of sugar that you've got in that. So that's what the nutrition facts table. Now, the other, of course, nutrition facts table has some limitations. And that's what you see on the right-hand side of this particular slide here. And first of all, it's on the side or it's on the back, so it's not sort of right up front when you're actually out there doing your shopping and stuff. It is, even though we think it's easier to understand now by sort of getting into this 515 sort of an approach, it's still kind of complex as well. And if you're into sort of comparisons back and forth, then you're sort of having to grab the things and look at the different stuff. And it makes it difficult. But at the same time, you've got a lot of front-of-pack messages out there with respect to nutrient content and health claims that are permitted through regulation as well. And in general, what these tend to do is highlight the positive elements that are in those foods. Usually, as in this, a source of fiber, you've got your oats in there. Now, the thing with the front of pack is it's voluntary by nature. I mean, there are regulations, but it's voluntary about whether you do that or not. And for the most part, it really gets used as a marketing tool, as opposed to perhaps from our perspectives, it would be in terms of a decision-making point per se. So where we are going, and we've gone out for a first, was really a pre-consultation that happened in the late fall, I guess it was last year, into January, is to look at how do you actually then regulate for front of pack labeling, which will make it easier for consumers to know whether a product has, my example here, of course, is high in sugars. That sort of we'll use, say, the higher than the 15%, sort of as an example. High in saturated fats or high in sodium. So what we've done in the proposal is then to focus on what we think of as the 3 nutrients of public health concern, bringing that sort of information from the side, bringing it up to the front of the pack, and then mandated for all products that are packaged that you would have right in the front of pack some sort of a label that would indicate whether you've got a lot of any of those nutrients of public concern. The exact, what that might look like, we're going out to POR in the next couple of months on that, and then we'll be back again for consultation on all of that sometime in the fall for what we call Canada Gazette 1, which is another opportunity for consultation before you finalize the regulation. So that's sort of what we have in mind, at least for proposals with the front of pack approach. Because saturated fat is one of the areas, I mean, I talked about this morning. I'll skip over this. Sorry for those of you who didn't hear it this morning, but it's just basically to say that even though there's some publicity from a report that came out yesterday about the effects of fats on health and stuff, that there is lots of very strong, convincing evidence from these particular organizations where they have graded systematic reviews and meta-analysis, and to show that the conclusion is that lower intakes of saturated fats when replaced by unsaturated fats are associated with lower risk of cholesterol, LCD cholesterol, and increased triglycerides. We agree with what came out yesterday in the sense that it's not for, I guess I am talking about it, about all-cause mortality or for heart attacks. That's nothing new. That's in our evidence reviews as well, which you can go see on the web as well. But there is justification for this. There's still strong justification to have saturated fats as a nutrient of public health concern. Restricting marketing to kids, and we had Manny gave a good talk this morning on this, so I will again not talk too long on this. This is again a commitment that the minister has made, is to have action with respect to restricting the marketing to kids. We know that most of what gets marketed to kids are very high, once again, in these same nutrients of public health concern, the saturated fats, the sugars, and the sodium. We know that the kids are bombarded with messages by all sorts of different types of media, and that they're getting these messages all the time. I guess the other thing is that most marketing to kids is actually with these types of foods that are high in it as well. We know that it has an effect with the whole pester power, and Manny talked quite eloquently about that this morning as well, to try and change the consumption patterns. We know that if you are eating these, then it sort of leads to, you're eating the raw, it leads to associated, we'll say, those types of foods with increased obesity as well. So the linkages are all there as well. So we are committed to introduce new restrictions in the commercial market of unhealthy food and beverages to kids. Manny talked to you, of course, about what's happening with Bill 228, Nancy Green-Rain's bill in the Senate. We are as well ourselves working on our sort of policy approach to this matter. We are focusing on these sort of 3 different areas, and once again, Manny sort of talked about these areas as well. One has to do with the age limits for restrictions, and Manny again presented to you what is in the bill right now is under 13. Manny has and the whole Stop Marketing to Kids Coalition, and he referred to Tom's work this morning as well, is trying to get that to be a higher one. We're looking at sort of what the evidence is across the board with respect to age limits. We're looking at what sort of foods and beverages to restrict, and sort of how do you actually put forward come up with, say, a nutrient profiling model that actually clearly identifies which foods can be restricted and which foods can't be restricted. We have a whole international steering committee that's helping us in sort of putting that together. We have assessed all the different models that are being used across the world to do this, and we have putting together our proposal with sort of a more made-in-Canada solution that is in line with all of the other sorts of initiatives that we're doing in our policies and our guidance. And then there's the third policy element has to do with the scope of the restricted marketing activities. So most restrictions out there, whether they're mostly voluntary out there, are focused on your TV and your radio. But of course, you get hit with marketing from all sorts of places, not just from TV and radio. And these other things are just increasing tremendously. So it's not, you've got the whole digital world, and there are all sorts of things that 10 years ago we wouldn't have thought of. Before it was the iPhone's been out there, for 10 years now? Could you ever imagine the types of advertising or marketing that's coming to us? 10 years ago, we wouldn't even have thought that you would be bombarded like this. I know why my grandson on a Saturday morning goes off and watches, he does do the watching TV type of a thing, not in my house, but in his house. But, well, actually, they live in my house now. I'm downstairs, and the grandpa got hit down to the basement. But, so he'll watch, and so in an hour or two, you get hit with somewhere between 3 and 5 commercials per hour. So you could say he does 2 hours, so he's got 10 times he's been hit with that. Then he'll be tired of doing that and say, I'm going to get on the iPad. Another thing that I wouldn't let him do, but I can't control my daughter somehow. I never could control my daughter, I suppose. But, and then what happens, of course, in a single day, there are 25 million different marketing approaches through the internet. Now, of course, he's not going to get all 25 million, but there are those opportunities out there as well. And just, it was about 3 weeks ago, I think he was onto the Lego thing, and all of a sudden I overheard him talking to his dad, and he says, Coke has a new healthy Coke there, the green one, because I sort of walked out and saw what he was looking at. Well, it was the Lego site, but they had sort of constructed a pop machine out of the Lego, and it sort of had the green and the red and stuff like that. So I said, you're looking at advertising? He said, no, this isn't advertising. I'm just looking at Lego sort of thing. So that's the sort of scope of things. Sorry, I got off track there. The scope of things that we're looking at. And there are going to be problems there as well, because, what do we do about international sort of contamination sort of with respect to the different media? What do you do about sponsorship? You get Tim Hortons who's sort of sponsoring hockey. Well, our parents are going to react nicely if we say, well, you shouldn't really be sponsoring that. You shouldn't be, because you're changing that whole food environment and sort of normalizing that. But we know that there could be reaction to those sorts of things as well. So those are the things we're doing, looking at in our policy proposal. In beginning of June, there will be a consultation coming out, and we'd sort of, all of you who are interested, love to have your input with respect to where we think we're going with respect to policy on marketing to kids. Revision of Canada's Food Guide. I've already talked about this to the rest of you here. But the bottom line is, let's just go to the bottom line for those of you who didn't see my talk this morning, is that we're moving in a very, very different direction with respect to how you'll get your dietary guidance. It's not going to be a 6-pager that will sort of try and be everything. We're going to create a whole suite of different sorts of tools that will be available, sort of mobile first, online, sort of you can sort of get in there and get the types of information you want. So whether it is for the basic, say, consumer and Canadian, it's really about these simplified messages and visuals, easy to come in and get that. But if you want to dive down and get more about our policies, if you want to have you can go as deep as you want, sort of type of a thing. So we're trying to create that sort of a working environment as well for Canadians. And then we talk about campaigns. Well, something that we're in the midst of right now, and we just had a whole day meeting yesterday with, I think we had about 12 or 14 different sort of stakeholder groups meeting with us, is what do we actually do about sugar-sweetened beverage consumption? And here, what we're looking at is really in teenagers, which is, they're where you get the highest amount of consumption. We're trying to, and working with, again, a number of stakeholders. And what's kind of interesting for this, all of a sudden we've got the oral health stakeholders coming in. So we have Canadian Dental Association, dental hygienists, we've got the dental technicians, we've got the dental therapists all around the table, as well as the heart and strokes and the diabetes and the different, the provinces and the territories and the different the different health professional groups. Oops, I'm about to get knocked off here. So, so basically, we're working on that side too, basically. And the idea is that, again, this common messaging, if you work together and develop the stuff together with government, NGOs, and health professionals, then you're going to have a much better, because you're giving the same messages from wherever they get it, you're going to have what we call a bigger collective impact. Ranges of different types of products for consumers, for health professionals to use with their different patients as well, are things that we think of developing as well. And how come it's not going forward? Senate report on obesity. I'll just point out, of course, that this is sort of the way forward from the Senate report. A lot of these different areas, having campaigns, banning advertising, implementing front of pack, redoing the food guide. We're full blast on all of those. They had another sort of area around taxation. We had really good presentations this morning on taxation. Just point out that's something that's not in health's mandate, that's out of finance, and I know that you guys have been working with finance as well on this. I will pop through, and it just comes back again to reinforce the health eating strategy, where we're taking this sort of larger comprehensive look and really hoping that this will help to create a much healthier food environment so we can actually make those sort of choices easier. So I'll just end there.
Thank you, Dr. Hutchinson. Thank you, everybody. Our last speaker is Jacob Shelley, who's a doctorate candidate in the Doctor of Judicial Science program at the Faculty of Law at the University of Toronto. He's also an assistant professor in the Faculty of Law in the School of Health Sciences at the University of Western Ontario. Please welcome Jacob. Thank you.
Thank you. So my talk today is to talk about the legal implications of reframing or discussing obesity as a chronic disease. And so I have some funding from the Canadian Obesity Network to look at obesity as a disability, and I have worked with the Stop Marketing to Kids Coalition. I have no commercial support, and I thought I'd be funny and talk about in my potential bias that I'm in counseling for never getting grants, because it's hard to get grants these days as a junior faculty member. So that makes me a little bit biased to those of you that may have grants. The real point of my talk today is to do two things. One is to talk about why classifying obesity as a chronic disease matters, and second, to talk about what it requires. And to specifically do this, I was asked to do this from a legal perspective. Now, yesterday, Dr. Friedhoff talked about the initials that are important for advocacy. So I'm curious if anyone has the following, LLB, in the room. Any LLBs, or JDs? So we have one who I'll mention later. And so I would point out that there are some really important advocates missing from this discussion often, which is a legal profession. And so my talk is to talk a little bit about why I think this is important. So very quickly, to start, I think we need to talk about what it means to classify obesity. Now, we've heard already about BMI, and if you've paid attention in the last few years, you've heard the phrase basically meaningless integer from Dr. Sharma. I would suggest perhaps also badly misused integer, right? That it's not necessarily meaningless, it's just really misused. But then what are we left with? Like, what are we actually talking about? And I've classified it as a non-scientist, as a legal scholar, as a you pick. You choose. What do you want to call it? Right? We have the options to call it a bunch of different things. And in fact, people like myself, shameless plug here, have advocated for ways to reformulate and rethink how we talk about obesity. I think we should just reframe it as caloric overconsumption is my particular recommendation that hasn't quite caught traction, but nevertheless, perhaps someday will. But we have this problem where we have now you pick what we actually are talking about, which I think actually helps create some more confusion that was mentioned earlier in one of the questions. And so when we talk about classifying obesity as a chronic disease, there's a few things I think that are really important here to talk about. First off, we can talk about what chronic disease is referred to and the idea of non-communicable. I understand in this type of audience, this should be straightforward, but not being passed from person to person of typically a long duration with a slow progression, right? And when we talk about chronic diseases, we usually talk about them in the framework of two things, prevention and treatment. And I think this is actually really, really important that we still talk about chronic disease prevention, as you'll see in a moment. But we also heard yesterday Dr. Friedhoff talk about how, in response to the report, we're still talking about lifestyle choices, right? And part of that's because we haven't been talking about obesity as a chronic disease. If we talk about obesity as a chronic disease, we can scratch out the lifestyle choices because, as Dr. Friedhoff mentioned, we don't identify a lot of other lifestyle choices in our discussion of chronic diseases, and we can start reframing about risk behaviors and risk factors. And that's actually a really important language to change. And as we'll see in my kind of concluding overarching theme is that for the law, words matter. How we talk about things matters. And then we can start talking about prevention in a different type of scope or a different type of frame. But also, I think, and one thing the Canadian Obesity Network has been great about that is often overlooked in the discussion about obesity because we haven't been talking about it as a disease, and specifically as a chronic disease, is management. And I think that the management piece is actually really, really critical from a legal point of view because we can talk about, and I won't here, but I'm happy to chat offline, about the role of a physician or of a healthcare provider. The ongoing duty of care includes the management of that chronic disease, not simply the treatment. Treatment is one option. Management is actually what's required. Treatment might be in the course of the management, but management's actually where we can focus, and we can talk about the legal obligations of physicians, of healthcare providers, to manage that chronic disease, which I think is an important shift away from treatment or prevention. Both are still very important, but I think we can actually start focusing a little bit more on management. So what does actually classifying obesity as a chronic disease require? So you guys are familiar with the 5 A's. I'm sure I could come up with more, but I've identified 4 A's, 4 alternative A's to think about when we think about classification. The first is agreement. This is going to be really, really hard. I'm always shocked when I go to events that we can't agree on things. And I understand why. I was at an event last May with Con where we had people that were from the critical obesity studies, the fat studies. We have different groups that have different mandates, different perspectives, and I think that's great, right? But that's when we're talking about obesity writ large. When we talk about obesity as a chronic disease, we have to come to some sort of agreement of what we mean. And clearly BMI is not going to cut it, right? So, perhaps we could think about things like EOS, right? The Edmonton Obesity Staging System, right? This might actually be a way to think about how we talk about chronic diseases and to eliminate that confusion that might arise so it's not 6 million people. Because, I'm pretty an open book. I have a BMI of roughly 34, 35, but I don't feel like I'm diseased. I would be in stage 0, right? I don't fit the disease framework. And I think that's actually a very important distinction. And I have other colleagues that have started to ask, what do you do about me? Because I don't fit what we think about when we think about obesity. And so we need to have some agreement of what it actually means. And that's actually going to be a lot of hard work. I think it's possible. We're going to need more than that, though. We're also going to need acceptance. This is going to be a little bit harder, especially for those in the room that work within the public health promotion field. We need to accept that obesity is a clinical issue, right? And this is hard, I think, to accept because we want to talk about prevention so much. But obesity as a chronic disease is a clinical issue which really is focused on the individual, not the population. And that shifting of the frame of thinking, that way we think about the problem, I think is actually really, really important, as we'll see in a minute. We're also going to have some acquiescence involved here. This is maybe reluctant, but we need public health to accept that obesity is a medical issue. This, I think, in this crowd, I imagine I'll get more support. In other circles, I don't think I'd get a lot of support for this at all. But we need to talk about it as a medical issue for very important reasons, as we'll see in a minute. And finally, we need some alignment. We need to, as people that work in public health, and I would consider myself among them, in health promotion, to start talking about chronic disease prevention and not obesity prevention. And Jimena has identified some really good rationales why that's important, right? Why we need to move in this direction. And so those are my 4 A's. So what does it all mean? What are and what does that require? So first off, it requires, in a basic sense, that accepting obesity as a clinical issue and perhaps accepting the public health policy needs to focus on healthy eating and not obesity, or physical activity and not obesity, or mental health and not obesity, etc. I think you get my point, right? And this actually requires that we reframe the problem that we're talking about. It's easy to talk about obesity as a problem. I do it as well. I fall into it. My own work has talked about obesity litigation, right? But it's not actually the problem. Obesity is the outcome of the problems. The problems are poor health related to mental health, healthy eating, physical activity. And I think identifying obesity as a medical issue, as a chronic disease, helps reframe that. And so I would say we maybe need to stop talking about obesity sometimes. And there's other frames we can use, such as diet-related chronic diseases, right? Like this actually, healthy eating is important far beyond obesity, as all of you know. And so if we started talking about diet-related chronic diseases, that actually might be very important. And why is it important? Because there are legal implications for defining obesity as a chronic disease. For example, in healthcare, if you're familiar with the Canada Health Act, the Canada Health Act requires that all insured services and physician services are provided, and these are defined within the language of medically necessary, right? When we had the discussion yesterday in the non-distinguished talk, where the discussion was about how it's a lifestyle, because it wasn't necessary. If we talk about obesity as a chronic disease, the Canada Health Act might actually be triggered more. This is probably why the government, federal government, doesn't want to actually talk about it as a disease, because that might actually have financial implications or responsibility, right? The Canada Health Act has medically necessary, medically required services being covered in order to get public funding, right? So if we talk about obesity as a chronic disease, it's really hard to say it's not medically necessary, right? And we can look at the report card for some of this. We could talk about this in the context of human rights. Human rights is a provincial matter. Every jurisdiction has its own human rights code, but often they define discrimination being prohibited on grounds, among many things, including disability. If obesity is a chronic disease, disability is triggered immediately. There's not a single human rights tribunal that would not identify a disability to include illnesses or diseases, right? This is important for two reasons. One, it would immediately provide protection for those that are suffering from a chronic disease, but also I think it would have the discussion generation around weight discrimination. And I think weight discrimination is different from obesity discrimination. And I think we do ourselves a big service to start talking about what it might mean to have weight discrimination. I had my law students actually do an exercise where I used Jimena's name, she doesn't know this, where I had someone being fired for gaining 20 pounds, right? And most students go, this is not obesity, it doesn't count. And I go, but it's still discriminatory. And we need to talk about that. And we can talk about it better if we can distinguish between the disease and the weight, right? There's two different problems happening here. And if you want to learn more about disease and disability in obesity, Sherelle Goodman, who's in the audience, will be giving a talk later today about this. And also we can think about what it might mean for policymakers, right? The actual framing of policy. And so I look at the policy objective. Last week I was part of an examining of a very well done master's thesis looking at the child care physical activity policies. And in the discussion, and Emily Ott is actually here and presenting, I think, on Friday, but in the discussion of this, the examiners talked about how we don't even need to talk about obesity. Physical activity policies are an end unto themselves, right? That can be the objective and not reduction of obesity. And we can think about how this might generate public support. So I've worked a lot on the marketing to kids issue the last few years. And if we frame it strictly as obesity, a lot of people would say this is not going to have any impact on obesity. If we frame it as chronic disease prevention, right, then we need to restrict marketing for chronic disease prevention. That actually might have a lot more traction. I don't have time to talk about how this might impact the judiciary, how judges might make their decisions with this reframing, but I'm happy to talk with you about that at lunch if you are interested. So to sum up, there are important reasons why classifying obesity as a chronic disease matters, right? And there's important reasons why we need to talk about what that requires from a legal point of view, because words matter in the law. That's all that we have in the law. We don't have charts, we don't have stats, but they may come in. We have the words that we use. And I would submit to you that if we started talking more about obesity as a chronic disease, that will have widespread, lasting, and important legal implications. And my clock tells me there's no time for questions. But thank you. Find me in the halls. I'm happy to chat later.
So, I'm a little speechless here. I wish we had another hour because those talks were so interesting and there was so much passion there that I think it probably stimulated a lot of thought. And I have no doubt that we could spend another hour just discussing a lot of what was presented today. However, I believe we're kind of inching into the Pechakucha, did I say that right? Pechakucha time. So I implore you all to please find the speakers and bombard them with your questions and comments, because I'm sure you all have many. And just a quick reminder that there is a lunch symposium in the Van Horn Ballroom at 11:30, I believe. So hopefully we'll see you all there. Thank you for your attention and have a great afternoon.